So what I'd like to do for the next 30 minutes or so is talk a little bit about the 1 hour bundle and is it too fast? Talk about some of the controversies and criticisms that we've received. This is my disclosure. I have some NIH funding and I'm on the scientific advisory board of a couple of companies. So I took out my slides about why all this attention to sepsis, because I think we know why there's so much attention on sepsis. I can tell you that in 2022, it is the most expensive condition treated in the United States. Over $60 billion a year is spent on sepsis. And it is the #1 cause of readmissions to hospitals. So that's why there's so much attention to sepsis. What I'd like to talk about is a little bit about the mandated and initiatives in sepsis that are going on currently. I'm going to talk a little bit today and later on tomorrow about the New York State mandated reporting that started in 2014. There are now proposed mechanisms for mandating sepsis performance in Pennsylvania, Illinois, Florida, and New Jersey. And so there is an increasing amount of attention to mandating performance, measuring performance in sepsis. In the United States, there is the SEP1 initiative, which adopted, and I'll talk about this in a moment, the 3- and 6-hour bundles from the Surviving Sepsis campaign, and now it's mandated reporting of compliance with those bundles since 2015. And finally, there's already a mandated reporting in the United Kingdom. There's one underway in Germany, and the WHO resolution on sepsis has also been accepted and published. So what are care bundles? And I want to take us through a little bit about what we've done. The most important thing about care bundles to remember is how we translate guidelines into clinical practice. Because remember that most of us get guidelines and then we put them on our desk and we often never look at them again. So really, care bundles are the way we translate guidelines into clinical practice. We did the original bundles by partnering with the Institute for Healthcare Improvement that's out of Boston, and it was founded by Don Berwick, who later ran for governor unsuccessfully and ran CMS for a while, which is our national funding agent. And we developed management change bundles. IHI is also famous for their ventilator-associated pneumonia bundles and their central line-associated bloodstream infection bundles. So they pioneered the use of bundles throughout. So the way they developed IHI, the way we developed bundles, was we did a thorough review of the literature. Then we pick out certain performance measures, and then we test them in a group of 15 hospitals, and we look to see which are being done the least, because the principle behind a change bundle is an attempt to get more product for the effort. That is, if, for instance, deep venous thrombosis prophylaxis is being done in 90% of patients in an intensive care unit, then we're unlikely to change very successfully. So the key is to find the elements of bundles that are being done the least, and we do that by testing it in 15 hospitals. And the key about bundles is that it's easy to measure and it's linked in time. So the original bundles, for instance, were lactate, yes or no, and was it done within 6 hours? So the original bundles were 6 and 24 hours, and they were eventually changed to 3 and 6 hour bundles. So linked by time and easy to measure are the key aspects of any kind of bundles. So these are the original, these are the, not the original, but these, I'm going to talk tomorrow about performance measures, but these are the current bundles that have been adopted that we use in the New York State Initiative, and that our national funding agency, CMS, uses and is adopted into the SEP1 performance metric. These are the 3-hour bundles, and this is the 6-hour bundle. So the 3 hours is lactate, whoops. Lactate, blood cultures before administering antibiotics, broad spectrum antibiotics, and 30 cc's per kilogram for patients who are hypotensive. And then the 6-hour bundle is apply vasopressors if your patient needs it. And then in the event of persistent hypotension, after fluid resuscitation, target 55, a mean arterial pressure of about 65 millimeters of mercury. And then finally remeasure lactate if the initial lactate is elevated. So the 3 and 6 hour bundles. So what I want to show you are the data that we published behind the bundles. And there are a fair amount of data that not only have we published, but a number of different groups have published on the 3 and 6 hour bundles. But this is from New York State. We published this in the Blue Journal in 2018. And you see here that basically this is septic shock, and this is the 6 hour bundle, and this is the mortality rate. This was 74,000 patients that were in the first 2 years of the New York State reporting measure. And you can see here a clear, statistically significant decline in bundles as the compliance went up over 2 years with the 3 and 6 hour bundles. This is also that what we were able to demonstrate is not only did participation with compliance make a difference, but the better you did, the more steeper your decline in mortality. So if you look at this, this is quartiles of compliance. The first is the lowest, the fourth is the highest quartile of compliance. And you can see here a statistically significant decrease in mortality over each quartile. So you can see here that the highest quartile of compliance had a mortality rate of about 23%, and the lowest quartile have a mortality of about 30%. So clearly, the longer you participate, the better, and the more effectively you achieve compliance, the steeper your decline in mortality. This is from the New York State Initiative. So each hospital, and there are 300 hospitals in New York State. So each hospital gets a monthly report that looks at measures the quartiles of performance. And you can see here, this is 3 hour bundle adherence. And you get the median of your hospital compared to all of the other quartiles in the database. That's your hospital compared to 300 other hospitals. It's because of these data that CMS adopted the SEP1 metric for a mandated reporting of sepsis in all hospitals across the United States. So why 1 hour? And what are the problems and controversies around 1 hour? Well, we published these data. We published these with Chris Seymour was the lead author, and we published this in 2017 in the New England Journal. And the most important thing that you can see here is that for every hour delay in completing the 3-hour bundle, this was, by the way, done in 75,000 emergency department patients. So this population was only emergency department. We did not include the wards or the ICU in this population. But for every hour delay, you can see a statistically significant increase in risk-adjusted mortality. This is risk-adjusted mortality, in-hospital mortality here, and this is statistically significant from the point, and the editors asked us to look at 12 hours. They didn't want us to we were going to use 6 hours because it's a 6-hour bundle, but they asked us to measure it out to 12 hours. And there's statistical significance between the 1 hour and 12 hours. So for every hour delay, and I'm going to talk about this with antibiotics in a moment, there is a statistically significant increase in the odds ratio of mortality. This is also true for antibiotics. So the administration of antibiotics, the longer we wait to get antibiotics on board, it's not exactly rocket science, as we say. I mean, it makes sense that in a patient who's infected, the longer we take to get the antibiotics on board, the higher their risk of mortality. And that's in fact exactly what we published in this article. We also published in JAMA, and we looked at children. So this is the pediatric population. It was about 1,000 folks altogether, 1,000 kids altogether. And what we were able to demonstrate was a statistically significant decrease in mortality when all of the elements of the bundle were achieved for children, and children was less than 18 years old in the New York State database. So, and we published this in JAMA. So really good data that suggests that the earlier we do things, the stronger the decrease in mortality in both adults and children. So that's the basis for why we developed the Hour 1 bundle. And I'm going to say a little bit more about antibiotic timing. So we published this in Critical Care Medicine in 2014. This is from the 30,000 patient surviving sepsis campaign database. We were able to show this is the first time that it was demonstrated in not only severe sepsis, the old definitions, but also septic shock as well. So we were able to demonstrate, this is septic shock, and this is severe sepsis. We were also able to demonstrate a statistically significant increase of about 7 to 10% for every hour delay. So we published it in the New England Journal and we published it in Critical Care Medicine. Again, it's not rocket science that the longer we wait to get antibiotics to a critically ill patient with sepsis, the higher their risk of dying. And so we published this. This is Vinnie Liu's manuscript that was published in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. It was published in 2017. It was also emergency department patients, and it was over 20,000 patients. I mean, it was over 30,000 patients, sorry. And I don't want to belabor this. I just want to show you this graph right here. So this reproduced exactly what several others have shown, that the longer you take to get antibiotics, the worse your patients are likely to do. Again, not surprising, but yet we still have to seem to prove that antibiotics are the key to survival along with fluids in patients. Well, what about fluids? So we published this in the same manuscript, and we looked at did you get fluids or not? And you can see here that this was also statistically significant. This was a 21% reduced risk of dying in the ICU if you got 30 cc's per kilogram. So these were critically ill patients. We published this in the Blue Journal, as I said, and it was statistically significant. So good evidence that the more fluid you give, when you give 30 cc's per kilogram, and I'm going to talk later this afternoon about the controversies in fluid management. So I'll have more of a time to talk about the controversies around fluid management. And obviously, there are a lot. I don't have to tell you all that. But needless to say, this is Vinny Liu's article on fluids. He looked at, he looked at 18,000 patients with a lactate of greater than 2 and less than 4. So intermediate lactate levels. And he specifically looked, and the bundle was, you see, it's the usual bundle. It was antibiotics within 3 hours and repeat lactate at 1 to 4 hours. And the most important thing to show you is in patients with a history of heart failure or chronic kidney disease, they actually were the ones that were statistically significant and benefited. So I like to say that more people with sepsis are killed by cardiologists and nephrologists than any of us, because the cardiologists are always worried, oh, my patient has a cardiomyopathy, so don't give them fluid. Or the end-stage renal disease patient who still is dry, still comes in after having a high fever, hiding under the covers for 5 days before they come to the hospital. They have distributive shock. They are effectively hypovolemic, but the nephrologists say, oh no, don't give my patient any fluid. And in this great study by Vinny, he was able to show that, he was able to show that the mortality in patients went down, in particular in patients with chronic kidney disease and cardiomyopathy. There it is right there. So you see here statistically significant hospital mortality decrease in patients with heart failure, history of kidney disease, and a history of heart failure. So really good data published by Vinny Liu, not by the Surviving Sepsis Campaign, that those folks in particular do best when they get fluids. Not surprising. Where did this all come from? So this is a manuscript that published, this was a patient-level meta-analysis published by the folks from Process, Promise, and Arise, the early goal-directed therapy, large randomized controlled trials. And I just want to point out, and I'm going to talk about this later this afternoon, but the important thing to remember about these trials is, remember Manny Rivers, when he first looked at early goal-directed therapy, he brought those patients in, and as soon as he measured the cetravenous oxygen saturation first, and then gave them fluid, and I'm going to talk about that later today, but here, prior to randomization, these folks, you can see here that the median amount of fluid they got was about 27 to 30 cc's per kilogram. So the median amount of fluid prior to randomization was about 30 cc's per kilogram. It's very important to keep in mind. And of course, if we give patients 30 cc's per kilogram before they get randomized, then it's likely that these trials will be negative, and that's exactly what they were. So we published this in 2018, and it caused a ton of controversy. We published in partnership with the European Society of Intensive Care Medicine and the Society of Critical Care Medicine in the US, the Hour One bundle. And at that time, we were using time zero was the time of presentation, which is the time of triage in the emergency department. And I think that was an error, because there's no question that if, especially in my hospital, I hate to confess this, but we've had people die waiting to be seen by an emergency department physician. And so choosing triage time as the time zero, I think, was a mistake. And so, but I just am going to show you some photos of the blogs that came about after this, because I think what we're fighting in particular is emergency department resistance. I'm going to talk tomorrow about an NIH-funded study that we're now doing, comparing the 1 to the 3 hour bundle. But here's what I think we're fighting against. This is just these are just some of the blogs that have been written. So, petition to retire the Surviving Sepsis Campaign guidelines. And and they compared us to the Death Star. And Josh personally compared me to Darth Vader, which I thought was a compliment personally. But just saying, but this is the kind of, so this is a graphic depiction of us suggesting 30 cc's per kilogram. They showed a tidal wave hitting Hawaii. A tidal wave, 2 liters of fluid, a tidal wave, 2 liters, right? That's exactly what people got in the 3 early goal-directed trials prior to randomization. 2 liters in a 70-kilogram person with ideal body weight. It's usually around 2 liters of fluid, maybe 2 liters to 2,500. I'm going to talk more about that this afternoon, but that's not a lot of fluid, especially not to compare it to a tidal wave hitting Hawaii. This is also by Josh, a pulmonary critical care sepsis research rant. Fake news, less real news. This is the response to the Hour One bundle. And this was published by my good friends, Mervyn Singer and Manu in The Lancet. This was in 2019. Let's see. Yeah. Sepsis hysteria, excess hype, and unrealistic expectations. These are the kind of reactions that a lot of academic physicians had to the Hour One bundle. Now, I do think that there are problems with the Hour One bundle. I really do think choosing a time zero as triage is really a problem. And I think it's more appropriate for septic shock, because we know that if someone winds up hypotensive and presents with hypotension, and we suspect infection, of course, we mobilize resources, people come immediately in from triage, and I think it's more appropriate for septic shock, which is sepsis itself is not often apparent immediately in the ED. So instead of triage time, we simply said it should begin 1 hour rather than completed within 1 hour. And the process for bundle revisions, and this is probably the biggest problem, we didn't have any emergency room physicians at the table when we redesigned the Hour One bundle. And that clearly was a mistake. And we paid for it with some of the blogs that I just showed you. So this is what we morphed the Hour One bundle into. This is to begin with 1 hour. And more importantly, we called time zero, the time of presentation is defined as the time of sepsis recognition. Now, CMS has also agreed with this. So they, for the 3-hour bundle in the emergency department, what they mandate is time zero is when I write in my note, I either write for an antibiotic and I choose a reason why, or I write in my note, I think this patient has sepsis. So that to me is much more realistic. The elements didn't change at all. It's the same elements, but we changed it to begin with 1 hour, not complete, and we changed the time zero. And I think that made a lot of people happy because we had the American College of Emergency Physicians. It's about 30,000 emergency room physicians in the United States actually wrote a letter of support to our NIH grant. So clearly everybody got on board once we changed the requirement for time zero. So there are a lot of problems in general with prospective cohort studies. There's clearly confounding by indication. So the delay is likely to occur in more complex patients. It's what I alluded to earlier about septic shock versus sepsis. It's harder to recognize if someone does not come in with hypotension, it can be harder to recognize that patient as sepsis, especially in a patient with coexisting cardiac abnormalities. There's no question, and we've received this criticism in almost every journal we've applied to for our manuscripts, there are less ill patients identified over time. And we know this from, we start to see sepsis everywhere. So the whole point is to suspect sepsis, but when we begin to see it everywhere, that means that less ill patients are identified over time. And finally, only outcomes for sepsis patients are reported. So we don't really know, and this really happened during COVID. We know that this was the case, that for patients, we know that patients were afraid to come to the hospital because they assumed they would get COVID in the hospital. So people with chest pain didn't come and have their MIs attended to. Instead, they stayed home and missed the opportunity to care for these folks. So there's no question that we're only looking at the outcomes of sepsis patients. So I just want to end by reminding us of the purpose of bundles. And I'm going to say more about this later this afternoon when I talk about precision medicine. Until we can truly personalize sepsis therapies, we know that there's wide variation in care. I'm going to show the same slide this afternoon. This variation is not just due to the physiologic variation of individual patient responses. It's also due to just not paying attention. We're all very busy, especially in the emergency department. There's so many things to remember. There are so many things to do that sometimes we forget to do the most simple things like give antibiotics or give fluids to our septic patients. As I said already, it's busy clinicians in a chaotic environment. The bundles are intended as a minimal response. Of course, you can do more if you want to do more. And I think the most important thing is that all the published evidence demonstrates a clear association between the bundle compliance and improved survival. So I think that the data strongly suggest early treatment is associated with improved survival. The data demonstrates increased mortality associated with every hour delay in management, whether it's compliance with the overall bundle, compliance with antibiotics, or compliance with fluids. All three have been demonstrated to be associated with increased risk of dying. Honestly, there are very little published data that demonstrates the deleterious impact of aggressive early treatment. That's really important because I showed you all the blogs and you'd think I showed you us being compared to the Death Star. And you would think that there's so much data about antibiotic resistance, and it's terrible what we're all doing And yet there are no published data that demonstrates a clear deleterious impact from early treatment. So the question is, why wait? And that's what I would leave you with, which is, why wait? I suspect all of us would want antibiotics as soon as we walked in the door. And with that, I'll say thank you.